Welcome, everybody, to this edition of Our Experience, ASCP's podcast. I am your co host, Chad Wers, Chief Executive at ASCP, alongside my tag team partner, Tom Hansel of Hansel Health. And we're going to talk about, in some ways, a forbidden topic today: money. So we have all these ways, to potentially make money, but we've got to educate pharmacies and pharmacists on what those are and make sure that they understand that there are these opportunities to kind of piece together a lot of payments for services that maybe they're not quite as aware of, or you just don't have the background to have done it.
Yeah, there's a saying that I've heard a couple times in my life. It says, "Tough times creates hard thinking men with innovation," and
And
then
women.
that and women, and those tough times and those innovations result in easy times, and that usually results in a situation where there's maybe a mentality of comfortability and ease. And so we're in a situation where we're having some really tough, challenging times. And so the men and women of pharmacy are starting to step up, starting to think outside that box of just getting paid to dispense drugs. And that creativity, I believe, will not just sustain us for the next couple of years, but I think it's going to create pathways for the future for us to continue to innovate and continue to utilize pharmacy services across a very, very wide spectrum.
Yeah, and it's kind of pulling pharmacy together. I think in some ways you've got packaging that's unique. We're going to make decisions about therapies based on the setting that you live in. So these convenient treatments that are out there that might be once weekly, might be once a day versus three times a day. We're going to make different decisions depending on where you live and what your capacity and capability is based on where you live. And all of those things have value. It's ultimately about people getting the right medications and being successful on the treatments that they're on. So there's lots of opportunity. This episode is one of our political football episodes. So welcome to Political Footballs. And we have a long time standing former employee, friend to long-term care pharmacy, Leigh Davitian, here to walk us through some of those opportunities. Leigh, welcome.
Thank you. Thank you both. Thrilled and excited and a tad nervous because I know Chad's going to bring me down somehow.
Not at
We've
all.
we've got good debates sometimes. We don't agree always.
Well,
So
it's a political football to talk about reimbursement. Fortunately, I think whether you're on one side of the aisle or the other, we're all for pharmacists getting paid more for what they do. So I think we can stay
absolutely.
out of the divisive.
Oh no, no, no! I don't mean that. We poke at each other even on the innocuous stuff.
No,
So
that's true. That's true.
yeah,
Well, let's
good
let's
heart.
let's get started. Like, tell us a little bit about what you've been doing over the past so many years in the long-term care space, and what you're currently focusing on.
Okay, so I just wrote a piece for the senior care pharmacist about the long journey of provider status. And I kind of started off being a little bit hyper focused on me, which I don't like doing, but I just thought it was a proper flow to kind of explain how 32 years ago, one of my first clinical issues was to help amend the Social Security Act to establish pharmacists as bona fide healthcare professionals because, as we all know, they weren't. And that was 32 years ago. So it kind of took me back to me literally sitting down my first 2 weeks at ASCP and immediately as a lawyer went to all the regulations and statutes that govern the practice of pharmacy and in particular long-term care pharmacy. And in this article for the senior care pharmacist, I said I was very excited that I found OBRA 87 because it established long-term care pharmacy and established the role of the consultant pharmacist and was mandated in a regulation. So that was great. I thought I conquered the world. Good job, Leigh. Only to not be able to find in the Social Security Act where you all were located in that language. I looked. It wasn't pre-computers, we did have the internet, but I kept thinking, like, I'm missing something. So I went to my very seasoned colleagues that were in the industry much longer, only to tell me, it's a problem. We're not in there. So I immediately, understanding how Medicare providers work, knew that that was a huge problem for pharmacists to ever be clinically identified for the acumen they had in the patient world. And here we are today. So at ASCP, as Chad knows and Tom, you know, we had to focus on both the clinical side, which was the consultant pharmacist. Since ASCP is a professional society, we focused on the clinical aspects of the pharmacist. But in addition to that, we did function like a trade association where we did have members that were long term care pharmacies. So I split my time as legislative counsel and as senior director of government affairs kind of equally, and was very passionate always for the clinical side. It wasn't that I didn't love working on the long term care pharmacy side, but I just had this passion for what consultant pharmacists did.
Mhm.
So let's jump forward to I left AACP in 2005 to start my own firm. And my first client was AACP. So they came along with me, or I came along still with them. But I focused more on the consultant pharmacist issues. So till this day, that's where my passion is. So, what I've been trying to talk about for years is I call service based revenue for pharmacists, not product based revenue. I don't want to get into separation issue where we're going to separate, obviously long term care pharmacies from the consultant pharmacists, but I always knew that there was this service based revenue that pharmacists could embrace upon. Now, we know the problem is the lack of provider status. That was the biggest problem. And that was a very big hurdle. But Chad, as you know, ASCP and its founders and the executive director at the time really thought outside of the box. And that was the biggest thing that ACP and I was attracted to was not being confined into a box the way that all pharmacy and pharmacists worked. We were taught to look outside. We were big supporters early on of MTM, diabetes management. A lot of our pharmacies did infusion pharmacy, wound care pharmacy, transplant pharmacy. So, again, that thinking outside of the box, there were in reality a lot of opportunities for pharmacies to do a very non traditional, diversified approach to
Mhm.
a product based revenue, but that again left the pharmacist out in a way. So, there was innovation in long term care pharmacy, but not as much with the consultant pharmacist. But the whole thing I kept talking about, and when I left ACP, in reality, those things really were out there. You had chronic care management, you had behavioral health integration, you had remote patient monitoring, you had psych evaluations. All those opportunities for service based revenue for pharmacists have been out there, but I'm one person. And the
Mhm.
problem that I had was no one seemed to really be pushing that these were the type of things that pharmacists could do. And so when I talk to pharmacists across the United States, because I'm still very involved with long term care pharmacies and consultant pharmacists standalone, I started talking more and more about AIMS, CCM, BHI, psych evaluations. And they're like, well, we can't do that. We don't know how to do that. We have to have collaborative practice agreement, all that. So I brought up the word incident two, to which I found out no one understood or knew what it was. So that is where I kind of reached out to Jaron Stout and Chad to say that I'd be willing to go on this journey of helping pharmacists understand this clinical service based revenue.
Mm.
Again, also helping long term care pharmacies with their product based revenue streams. But to really finally get pharmacists to understand in this 32 plus your journey of you don't need provider status necessarily to be able to be paid for your clinical
Right.
services. And that's what I'm all about. And I know that was long. I apologize.
No, it's
Maybe you
good.
edited me out, but it's just kind of my journey for 32 years of getting consultant pharmacists to just not do over 87, to
Right.
just not do the requirements of a mandate, which is a single regulation when there's all these other opportunities for them to be paid for their clinical services. But again, the problem is there's not a lot of pharmacy organizations that are really promoting some of this, and or pharmacists don't understand that they can even do it.
I think that's the critical piece, is that we're not talking about once we get provider status we can do. We're talking about right now there are multiple ways to get reimbursed for your clinical services today. They exist, some of which were amplified because of the flexibilities during COVID. Some of that amplification will continue, but beyond that, these are things that you could start tomorrow, arguably,
Correct,
and get paid for.
correct,
And
correct.
we have to we have to do a better job of getting that out to the pharmacists and the pharmacies so that they start adopting some of these procedures and realizing the benefits of that. So yeah.
Yeah, I think people will change when they learn enough and they receive enough information. And that's basically
Yeah.
what your mission is, right? Is to provide that education. And I think that the resistance to change has been that it's just an area they're not very familiar with and not very comfortable with, and they do go back to doing what they know to do, which is dispense drugs.
Correct, correct. But what's interesting, Tom, is that the pharmacist that I'm talking to, and I've talked to Chad about this for a while, I'm talking to a lot of innovative pharmacists, and, and most of them are young, not all of them. Some of them want to reinvent themselves that have been doing this for a long time. And I've been in this industry as a non pharmacist, of course, but I feel like I've been, deemed one on TV. I can play one. But it's interesting to see that it's not that they disdain or dislike the long term care pharmacy dispensing component. That's just not what they want to do. They want to be
Right.
very clinical and very innovative. So they're dying to understand, like when you use words like value based care, collaborative care, collaboration, team based approach, they want to know how can we be a part of value based care, team based approach, collaborative care teams? Like, how do we do it? And can we do it? And with that, once they understand that, they're getting into not only geriatric pharmacy but pediatric pharmacists, cardiology pharmacists, oncology, PGX, behavioral pharmacists, nutritional pharmacists. I mean, they're finding out that this collaborative care, value based team approach is out there, and other healthcare team members want pharmacists to be a part of this team. It's just getting them to understand that they can be a part of it
Mhm.
through regulations, and then to get them to understand the regulations, and then get them married to, introduced to these medical teams that desperately want to use them. So it's kind of educating the pharmacist and educating the organizations and education the physicians that pharmacists can be a part of these teams.
Right. Do you think some of this ownership falls on the pharmacy schools to be able
Oh
to
God.
broaden their understanding of what a pharmacist can do?
Well, I mean, let's try to analogize it to law school. Law school has evolved some, but in the way it hasn't, because you have to learn basically tort law, contract law, constitutional law. So it doesn't evolve and be overly trendmatic in a way, but the industries are changing in the legal field, just like in pharmacy. And to keep up with the times, the curriculum has to change. But in both of those institutions, the curriculums are not really keeping up with the times. And they don't like using the word trends because they're academic institutions. Everything's molded in history and the way it's always been done. So my answer is to that, yes, that I do believe that there is some of the onus placed on the college's pharmacy. And one of the caveats I wanted to say before I started was I'm going to kind of poke at everybody, organizations, political groups, schools, colleges, pharmacies, pharmacists. In a way, there's a lot of people that are not rising to the occasion to help the pharmacist be able to thrive and to be moving with the times. There's so many opportunities out there, and it's really, for me, discouraging to see how little people are embracing it. And I think it's a lack of education and understanding. So one of the things I'm trying to do with AACP is to get that message out, since I kind of understand the nuances of a lot of the regulatory leeway that they have to do these type of service-based revenue streams.
Yeah, and we saw that with, I mean, vaccinations is the poster child of kind of this endeavor. We weren't long-term care pharmacies and pharmacists were not vaccinating prior to COVID. They just simply weren't. They were in a supplier relationship with nursing homes and assisted living facilities. They would deliver the vaccine, but then the nurses at the nursing home would take over and they would administer those vaccines. They would, if they were sophisticated enough, bill for those vaccines. If they weren't, they would even do it as a loss leader. And then COVID hits, and the first people to say, we can't do this, we need pharmacists to do it, were the nursing homes. They're like, we can't do this. So all these flexibilities happen. Pharmacists that were working in long-term care that, before that were not vaccinating, started to become immunizers, started to vaccinate, kind of pulled themselves, you know, back toward what was already happening on community pharmacy where they were vaccinating, and realized that there was an opportunity there, that you're getting paid for something that's not just the product. You're getting paid for the administration of the vaccine. And I still believe there's a substantial opportunity there for pharmacies and for pharmacists, because however we got here, we're now in an environment where the older adult has multiple annual vaccines that they need, whether it's a COVID, an influenza, or an RSV vaccine. These vaccines are not cheap. They used to be cheap, but now with the high dose or adjuvated flu, you've got two vaccines that are $130 approximately each, and you've got an RSV vaccine that's probably $250 to $300 a vaccine, and you get paid anywhere from a $30 to $40 administration fee if you deliver that vaccine into somebody's arm, and that's opportunity. But I still see pharmacies out there going, I want to go back the old way where I send a box of 100 vaccines and I don't have to touch anything after that. And it's kind of like, we're not going to get the provider status I think that you envision in in some ways. We're going to get it line item at a time, but we also have to be responsible to take advantage of what we are given. So if we have this opportunity with vaccination, we should own it. We should, long-term care pharmacies and pharmacists should own vaccination. There should be responsible for it. There's a lot of benefits to for pharmacies being responsible for vaccination. But that's just one example. But it kind of tells the story of what you've experienced, that hey, these things exist, but man, is it hard to get people to move off of the way we've always done it and do it differently and go after it.
But they want to,
They
Chad. So
do.
that's,
They do.
I mean, that's where it's exciting because I think, with
Well, you
your
say
work,
I will. I'm push back. We'll do a little poking. You say
yeah,
that
do.
you say they want that, but a lot of those independent consultant pharmacists don't want to vaccinate.
Okay, so now I do want to tell you that a number of the consultant pharmacists that I talk to, or what I call the innovators, I call them the young innovators, the young mavericks. I mean, they'll say things like, Leigh, I don't want to dispense ever. I don't want to touch a product. I don't want to stick a needle. It's not because I'm afraid to put a needle in someone. I don't want to be attached to a product. I do not want to do that. In fact, something on LinkedIn the other day, I almost liked it, but then I didn't want to be a pharmacy hater, and I didn't click like. But it was like, I will never dispense again. And then like all these people are pushing like, because they want to be known for their clinical acumen of working in a team-based approach with patient interaction to optimize the care, not be attached to a product. And that goes as far as literally not wanting to do vaccinations. Now, is that extreme? It was at one point, but now the more of these young pharmacists I'm talking to, it's not.
Well, it's not.
Yeah.
I think we suffer the consequences of a retail or community practice where dispensing and vaccinating have become so manufacturer like and quota driven that there's that initial, you know, pushback that I don't want to do that. But what I would say as a former entrepreneurial consultant pharmacist that primarily only did the clinical work in the nursing home as a consultant, I would have embraced the vaccine piece because in my mind, if I could coordinate with that pharmacy and I could have them ship the vaccines that I needed to administer the days that I went into that nursing home, and I could get paid, anywhere from $20 to $40 for each vaccine I gave, I'm already in that building. I'm already doing patient care activities and clinical work. Yes, the function of administering a vaccine might not seem clinical and attractive, but being responsible that somebody is up to date on all their adult vaccines is something I feel like is clinical. It is something that I think she should be proud to be responsible for. So I just, and I'm not trying to pick on anybody. I'm not. But but what I am saying is these things that are out there, we're not even the people that are motivated to do more. They have to be able to accept some of the things that aren't great and be able to do some of the things that are great.
But
Make
yeah,
it
I
all
mean,
work.
it's both sides, right? I can understand Lee to your point, or the pharmacist you were talking to, they don't want to be known for a transaction. I
Correct.
have to do so many sticks per
100%.
month, or dispense so many drugs per month, and they want to be used for their mental capabilities, and
Right.
how they can you know be a bigger part of the entire health system. But again, we're not 100% there. And so there
No.
certainly is, as we continue to centralize and continue to, to kind of assembly line a lot of the dispensing of the drugs. I think the vaccinations provides that bridge between that
Right.
pure transactional to clinical.
But see, I think with the legislation that, has picked up traction in this Congress, that APHA, ASHP, ASCP, and others are supporting the ECAPS legislation. I mean, that's a good indication that it will probably happen, that it will be here to stay post COVID, post PHE. And that's a great mini provider status. It's not full provider status. It's going to be a while for, I think it might be another, maybe not 32 years, but it's going to be a while. But it's a big
It's
victory.
a foot in the door, and it does
It's a
give you
good
some leverage
step.
to.
But
uh,
I call those little mini provider
yeah.
status. When I was in law school, I had a professor that talked about a means to the end. You're on one side of a bridge and you need to get to the other side of the bridge. And you don't have concrete and you don't have steel, but you got paper. And so you kind of make this paper bridge to get from one end to another end. It's not permanent, it's not
Yep.
sturdy, but you can kind of get from one issue to the other side. For me, I see a lot of these little things like CCM, BHI, wellness, psych evaluations, AIMS, Incident 2, they're all branches of Incident 2, is being many little steps in this paper bridge called provider status. It's like allowing us to get to the end side, which is pharmacists being reimbursed for their clinical services. Maybe not directly, because they still have to be under the supervision of a physician in most of these opportunities, but they're still getting the ability to be paid for their clinical services. It's like pre-provider status on steroids. So the vaccination piece to me is an important mini provider status,
Right.
but so are all these other
No,
options.
100%. And let's talk about, I mean, two I definitely want to get to, but the first one being the behavioral health piece of it. Um, and I'll give a little brief background. Incident to billing generally before COVID required direct supervision by the physician, meaning they had to be in the building at the same time you were in the building. Your service, you could bill through that physician as so long as that physician also didn't try to bill a service on that patient on that same day, which made it for nursing home and um, arguably assisted living consulting impossible because you were never going to be under the roof with the physician provider. Now there's exceptions to that, but for the most part, you're not like a hospital where you're under the roof, same roof. They flexed that during COVID for obvious reasons, recognizing that people weren't going into these settings, and they allowed indirect supervision, which meant you just had to have telephonic or electronic access to the physician if you were going to provide an incident to service, which opened up a door for pharmacies and for pharmacists. A few pharmacists recognized it and started doing it. They've since put a limit on this ability of the end of this year, December of 24, and it's in limbo whether or not they will allow that indirect supervision to continue. Save behavioral health, which they have allowed to continue, I don't know, indefinitely with indirect supervision. So, again, on one hand, we're getting this opportunity with behavioral health. So, I want to talk about that. And then talk about what that means for the other clinical services that don't fall under behavioral health that may not have indirect supervision starting January 1 of 25. So talk about behavioral health.
Okay, so can I go?
Yes.
Can I can
Adjust
I
my narrative.
can I
Yes.
can I dog ear that moment
Yeah.
and then come back to it? Okay.
Yeah.
So let's go to incident. Let's just explain for all these lovely viewers what incident two is. I mean, you mentioned it, but you've got to have a physician that initiates the first direct patient interaction. There has to be a diagnosis, there has to be a treatment plan. And then after that first encounter, a non physician practitioner, which pharmacists are not considered to be, but an auxiliary personnel under incident two, where a pharmacist can and is considered auxiliary personnel, can provide follow up on that care treatment. Okay, so that's like there's 7 steps and requirements to incident two. The services are usually provided or those that would be provided in a physician's office. So we're not going to be doing any surgeries or anything. Um, and it requires a physician to have an ongoing management or supervision of that non physician practitioner or auxiliary personnel. So, right now, incident two allows, because of COVID, expanded the flexibilities under the public health emergency, and they've been continuing to happen until December 31st, 2024. But there is 2 pieces of legislation that are out there to expand the flexibilities of the supervision and other flexibilities, ad infinitum. So supervision right now is what they call general. So you don't have to have the physician present, but they still have to have ongoing management. They still have to be involved, but it doesn't have to be direct. Incident two cannot be in an institutional setting, rendering services to institutional patients. It has to be non institutional patients. So, acute care facilities like hospitals and skilled nursing facilities. Now, we all know there's a difference between SNFs and NIFs because Part A stay you're institutionalized. Part B stay, you now have evolved into a residence and a non institutional patient. So, incident 2 can happen in a nursing facility, Part B. The reason why I'm getting to this, Chad, is people do not believe that pharmacists are considered auxiliary personnel. They absolutely are. It was clarified by CMS in 2006, and this is what's frustrating to me. A pharmacy organization didn't get that clarification. The American Academy of Family Physicians wrote to CMS and said, can we incorporate pharmacists as part of our care team? Can we collaborate with them, supervise them, manage them under incident 2? Are they considered auxiliary personnel? CMS came back and said yes. Pharmacists can be a part of incident 2. That's a big misnomer right now. A lot of people do not believe that pharmacists are auxiliary personnel, and they do not believe that they're able to do incident 2. So then the next thing was that the supervision was a problem, especially for consultant pharmacists working in institutionalized settings like SNF, NIFs. So we got the qualification, got the clarification that it can be done under the Part B stay. And then the other thing that you have to be able to do is you need to make sure that you look at your MACs, your Medicare administrative contractors, to make sure that they are on par and have an understanding before you start doing billing. So the reason why I wanted to bring that up, Chad, is you're explaining incident 2 is great, but if people do not understand that pharmacists can do this, it's a problem, because 9 out of 10 pharmacists that I've talked to or pharmacies have said no, they can't do it.
Correct.
They can't do it for all these reasons. And I'm like, nope, 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 nope.
Nope.
So
But what you're saying is, nope, you can do it. Nope, you can
you
do it.
can do it. Like you're wrong, you're wrong. Your interpretation is wrong, you're wrong, you're wrong. Because think, I mean, I'm going to get a little bit in the weeds, but you've got healthcare professionals, qualified healthcare professionals, auxiliary personnel, and clinical staff. All of those are defined in different regulations, and it gets very confusing. Pharmacists are considered healthcare professionals, not under Social Security, but under many regs. And in general terms, they're a healthcare professional. They're not a qualified healthcare professional, which pharmacy organizations should be pounding that home
Right.
every day, because that would open a lot of opportunities. You guys are auxiliary personnel and you guys are clinical staff. So when you read these regulations and these billing mechanisms and these service-based revenue opportunities, you need to make sure that you recognize where pharmacists are defined, that they can move forward. And one of those happens to be a lot of the behavioral health.
So let me give
So I'm,
you let me give you an example and just respond to it. So I'm working in a nursing home, and the
yes,
SNF side, the non-SNF side. So I mean, just as from a garden variety standpoint, most nursing homes, 100-bed nursing homes, 25 beds are transitional Part A beds, 75 are residential Part B beds. So I'm working with that group of 75 people. My physician that I work with, medical director or attending, um, has a number of patients on psychotropic medications. They're already established, that's their doctor. These therapies are already established. You know, a big function of consultant pharmacist is to make sure from a regular, and I want to be clear about this, from a regulatory perspective, we're doing gradual dose reductions. We're making sure that the patient is free from adverse effects. But what I hear you saying is, if I had a relationship with that physician, and
a contractual, you have to have a
it's not collaborative practice, it is a business
not, it
contract.
is a business agreement where you are hired as an auxiliary personnel
Correct.
and the doctor can deem whoever he likes to be
Yeah.
that auxiliary personnel, and pharmacists can be and auxiliary personnel.
So then I have this relationship with my physician, and I am making dose adjustments or assessing, like you had mentioned, like Ames test or drug monitoring, that those things could then be billed to through that physician, and that
Correct.
pharmacist can be reimbursed for that activity.
Correct.
And that falls under behavioral health, and that
Correct.
exists from now until the end of time. I guess it exists. It's not going away December
Right.
31st. So that snippet is factual.
Yeah. Factual. But okay, yes, that correct. That is exciting. But in addition to behavioral health being exciting, just like the vaccination, this is all kind of evolved out of COVID and telehealth in a way. These other things exist, Chad, out there: CCMs, BHI, RPMs, wellness, psych evaluations, AIMS. Those can be done currently through a business agreement with a physician, and they are not hindered by the supervision issue. They can be done by general supervision. So, my question is, up until 2006, no pharmacy organization clarified that pharmacists could be a part of Incident 2. Everyone just thought, nope, it can't happen. We're not a qualified healthcare provider. We're not an MPP. But no one tried to identify that they're an auxiliary personnel, and that's all you have to be. So currently, all these young pharmacists that I'm talking with are doing CCM, psych evaluations, are remote patient monitoring under under the general supervision of a physician that they have a contract with. And remember, it can't be a new event. It has to be part of the treatment plan. It has to be established by the physician and the assessment of the physician. So it's not like a pharmacist can all of a sudden find a new event and start doing collaboration and services. So they can right now do all of those things without worrying about the direct supervision issue because it's a general supervision. So auxiliary personnel, aka pharmacists, have a contractual relationship as a 1099 or an employee of a physician who they do services incident to that physician's first diagnosis and treatment plan. They then the pharmacist render those services, bill the physician for those services. The physician bills Medicare through their NPI number. So those pharmacists are being billed for their clinical interventions, not the physicians, because it's incident to the physician. That right now can be done.
My question then is, what you're saying, really the only potential barrier to a pharmacist in that situation going out tomorrow and starting to do this, maybe there's one and a half barriers. The first barrier is you need a relationship with the physician,
Correct.
and that's in the form of a business contract, not a collaboration agreement. It's a business contract. Anybody can do it, all 50 states.
Right.
I was just going to say number two, or the half is, and maybe it's not even a half, that whoever the physician bills has to be aware that these are legitimate bills and pay those bills.
Of course, they have to worry about wrongful billing.
Right.
So anyone who has an NPI number and is a Medicare enrolled professional is
Right.
responsible to meet all the billing requirements and not file a wrongful
I guess my
claim.
question is, if I start doing it tomorrow through my physician friend who I'm now contracted with, is their MAC going to question these new bills that they're seeing, or are they just going to not, because it's part of the bill that comes from the entire practice and it's kind of weaved in there?
Okay, so that's where everything gets a little bit tricky, and that's why if we had 4 hours, I could probably explain this a little bit more clearly and not redact it and make it a tad confusing. And I apologize if I'm kind of all over the place. It's a really complex. This whole issue is very complex. Probably one of the harder issues I've worked on in a long time. So the federal government is telling you through Incident 2 regulation that was created back in the 1970s. It evolved in the 1990s, and then it started getting more teeth when nurse practitioners, physician's assistants, critical care nurses came into play. So um, it is pretty much a given that you can do most of these things through the evolution. And I'm trying to figure out, there's a lot of different things, but the federal regulation allows you to do it. But I always tell people you've got to check your max and your state laws. A state law is not going to stop it from happening per se. Now, some pharmacists are going to reach out to the board of pharmacies and say, can I do this? To which I would say, why are you bringing in the board of pharmacies to be a part of a contract that you have with the physician who has hired you as a 1099 employee or independent contractor or an employee? The board of pharmacy really doesn't have a place in that. We're not talking about dispensing drugs. We're not really talking about what the boards of pharmacy govern. So if you want to check your state laws, do it. But you do want to check your max. And the max, you want to make sure, like you said, Chad, understand that I'm about to do this. And what is your interpretation of Incident 2 as it applies between a physician and a pharmacist and a contractual relationship under the federal Medicare Part B billing mechanism known as Incident 2?
So I guess the argument for your physician that you're contracting with is that their billing personnel reach out to the MAC and say, "Hey, we've hired a pharmacist to do some work for us. We're going to start billing these codes and these activities. I just want to make you aware of it. So if you have any questions, you can reach back out to us with those questions." It's almost like, I'm not asking you if I can do it. I'm just telling you that it's coming and be aware,
Yeah.
and then let them respond from that standpoint.
Correct. Now, I will tell you, a lot of people that I'm working with right now, they don't. They don't reach out to their max
Yeah.
because we already have an understanding
Well,
of
yeah,
what
that's
that max.
the other answer is don't, do it unless it gets
It'll be like they already know their max or understanding of how it works.
right.
Part of the problem is when the max say you can't do it, the max will say you're not a non-physician practitioner. So then we have to educate the max that we know we're not a non physician practitioner. We know that we're not a qualified healthcare professional. We don't need to be one.
Right.
We just have to be defined as auxiliary personnel per the regulation. So some max are like, oh, okay, we're a tad confused. And then what we'll do is we'll bring in the letter from 2006 that the American Academy of Family Physicians clarified, not pharmacy organizations, where it says pharmacists can do Incident 2 as an auxiliary personnel, and it's still standing. And then the Macs are like, we get it. It's fine. We got it. We've got it.